Today's speaker is Dr. Nathaniel Chin, who joined the Alzheimer's Research Center at UW Hospital in 2017. Dr. Chin's father was diagnosed with Alzheimer's when he was in medical school, which had a huge impact on his career choice. He decided to focus on Alzheimer's disease and dementia. His particular area interest is understanding the role of lifestyle on cognitive health trajectories. And today his speech is entitled, Build Your Brain Buffer, Lifestyle Changes that Lower Your Risk for Alzheimer's Disease. I think we can all benefit for this. Please join me in welcoming Dr. Daniel Chin to the stage.
Thank you for that introduction. I'd like to thank the Rotary Program Committee for inviting me to speak today. I'd especially like to thank Ms. Carol Colby for suggesting me. And lastly, I'd like to thank all of you for being here. It is my hope that you leave with one or two ideas on how to build your own brain buffer as I talk about lifestyle changes that lower your risk for Alzheimer's disease. My other objectives include explaining the many definitions of cognitive impairment, discussing Alzheimer's disease, and then reviewing some key research findings indicating the importance of lifestyle factors. So to start, I want to explain what normal aging is. And so you're going to see this figure throughout my presentation. And on the horizontal axis is age. So you're getting older as you go from left to right. And on the vertical axis is cognitive function, or brain performance, or thinking ability, whatever term you prefer to use. But as you are going from bottom up, we see an improvement in function, or as you're going from top down, we see a decrease. And you'll see this line here, that represents normal aging. And one of the first things you should observe is that it's not a straight horizontal line. We know that with normal aging, there are declines. Unfortunately, if this is the first time you've heard that, I'm sorry to be the one. But this does happen, and I would imagine many of us are experiencing it. We do actually believe aging starts to take a role after the age of 30, so we start seeing those declines then. Now, this is just a general graphic, so this doesn't represent each and every one of you. But I want us to be aware of that because some of the changes that we experience are we learn at a slower rate. We're less efficient, we need more repetition, but we are still learning. Our processing speed and our reaction times are slower. Our free recall becomes more difficult. And this is when we're in a conversation and we're looking for the right word or the right fact to defend what we're saying. And as we get older, we may need more cues for this. Now, word and name-finding problems do exist in normal aging. It's one of the most common complaints I get in my memory clinic, and it's one of the least sensitive ones. Now, less cognitive flexibility occurs as well as we get older, which is really just a fancy way of saying we're more easily distracted as we get older. Now, the good news is that with age comes wisdom, as well as emotional resilience. Our ability to handle these changes is better as we get older compared to our younger selves. And so what that means is we're handling the changes that we are describing here, and we're not seeing day-to-day functional impairments. So if this is normal aging, then what is abnormal aging? And that's when you might hear the term cognitive impairment. And I have a picture here of an umbrella, and I want you to think of the term cognitive impairment as an umbrella term, a descriptor term to describe what people are experiencing or what others are observing. And when a person has a subjective memory or thinking complaint, that is a part of it. It could be observed by the person or someone close to them. And then this person has to have the courage to go in to be tested, because on objective testing, we see a low score or an abnormal score. And there are two main types of cognitive impairment, and that's mild cognitive impairment, which is also known as MCI, and dementia. But I want you to think of those terms as umbrella terms as well. They're descriptors of what a person is experiencing. So for dementia, in 2011, the National Institute on Aging and the Alzheimer's Association got together to define and develop the criteria for the clinical diagnosis of dementia. And what they said is that we need to have cognitive symptoms that we detect through a good history as well as through objective cognitive testing, that these cognitive symptoms represent a decline from a person's previous level of functioning, and that we've ruled out things like delirium or acute confusion or a major psychiatric disorder. And most importantly, this person or these cognitive symptoms interfere with our ability to function in usual activities. So the term dementia is a syndrome. It describes what people are experiencing or the symptoms that we're seeing. But it's not a disease itself, and that's important because many diseases cause dementia. Now, Alzheimer's disease is very common and many people have heard of it. It is the most common cause of dementia. 60% of cases alone are due to Alzheimer's disease, but another 20% can be accounted for when it's mixed with some other condition. So 80% of cases can be due to Alzheimer's disease. But it's also important to look for those other causes, and that includes cerebral vascular disease or blood vessel disease in the brain, such as strokes, or just having a lot of narrowing of the blood vessels in the brain, Lewy body disease, frontal temporal disease, Parkinson's disease. But there are other less common kinds, and that's autoimmune, infections, vitamin deficiencies. So if this is dementia, then mild cognitive impairment is not normal aging, but it's also not dementia. And in mild cognitive impairment, similarly though, you have memory or thinking problems. Again, observed by the person or observed by someone who knows them well. And these problems represent a decline from the prior baseline. And then they go through testing, and we do find impairments on the testing. Now, in general, those impairments are not as severe as someone with dementia, or there might not be as many impairments as someone with dementia. But the key differentiating thing is that there's not a day-to-day functional impairment. And so again, mild cognitive impairment is an umbrella term. But the same diseases that cause dementia can also cause mild cognitive impairment. But in addition to those, we also allow for underlying medical conditions. These are things like your thyroid, so having a thyroid disorder, medications, or psychiatric disease, depression, anxiety, bipolar disease, schizophrenia. These can cause mild cognitive impairment. So Alzheimer's disease can cause both mild cognitive impairment and dementia, but it is not the same thing as those terms. Alzheimer's disease is the actual abnormal process that occurs in your brain. So in Alzheimer's disease, this abnormal protein called amyloid or beta amyloid is building up. We believe we all develop some form of amyloid, but it's usually cleared in our brain, we believe, during your sleep. But in people with Alzheimer's disease, this protein is not cleared, and it forms clumps, these sticky, toxic clumps, which we call plaques. And then these amyloid plaques then induce a change in the actual brain cells, which we call neurons. And that change, it's a reconfiguration of a protein called tau, and that tau forms tangles, or neurofibrillary tangles. So now we have amyloid plaques, and we have tau tangles, and there's more inflammation in the brain. There's more oxidation, there's more excitotoxicity, and all of that means is that it's leading to neuron cells dying. And when neuron cells die, they can't communicate with each other. They can't tell our brain, remember this, or process this information, or follow these directions. Because when there's no communication, there's this deficit in the actual signals that we use to communicate, a neurotransmitter deficit. And when that deficit exists, we have symptoms, and then we are diagnosed. So this figure that you see in the right side of my slide, that's two autopsy slides. The top one shows the tangles inside of a brain cell, and the bottom one shows the amyloid plaque that exists among brain cells, not inside. So now I'm here to tell you that just in 2018, we changed the definition again. And this is only in the research world, but the same organization, the National Institute on Aging and the Alzheimer's Association, got together and changed the framework for how researchers view Alzheimer's disease. And that's important because what we're saying is that this disease, Alzheimer's disease, is a continuum rather than distinct clinical entities of mild cognitive impairment and dementia. Because we know from clinical experience that dementia due to Alzheimer's disease is actually occurring quite gradually. So this is that figure I showed you of age and cognitive ability and that natural change. But now I want you to imagine that as we're getting older, we're accumulating some of these Alzheimer's disease changes, the pathology of amyloid plaques and neurofibrillary tangles. And at some point, there's this tipping point where our brain can't handle it anymore, and we deviate from the normal trajectory of normal aging, and we become this red line. and this red line shows more rapid decline. And that's because we're starting to have disease. And depending on how significant those symptoms are, you may present to my clinic and I will diagnose you with mild cognitive impairment at some point. Or maybe you don't and you wait longer. But at some point you come in because these symptoms are pretty severe and you're having functional changes. And then we'll diagnose you with dementia due to Alzheimer's disease. And so in essence, what we're really doing is we're shifting the definition of Alzheimer's disease from clinical symptoms to the biological definition of amyloid, tau, and neurodegeneration, A, T, and N. And again, this is just in the research world, but what happens in the research world later echoes what we do in the clinical world. And so if we're going to use this biological definition in research, we need to have the ability and the technology to detect these biological changes in someone living. We can't wait until an autopsy to confirm these things and to study these things. And fortunately, we do have that technology. In fact, we can detect pathology in people without symptoms. And this is a hypothetical situation of a 70-year-old woman who has no cognitive complaints. But then when we look at her MRI scan, there's these little small circles right in the middle of it. That's called the hippocampus. I don't know if I have a laser. I don't. But so the hippocampus is the region of our brain where we store our memories. And it's a little bit smaller in this figure. Or if I had a glucose PET scan, I could show that the areas of the brain suggestive of Alzheimer's disease aren't working as well. And then I have a PET scan in the middle, and that is an amyloid PET scan, so we can actually detect protein in someone living, the presence of that protein. And the same thing on that far right side. Those are tangos, so that's a tau PET scan. We can do the same thing in cerebral spinal fluid when our participants donate and do this lumbar puncture and donate their fluid. So we can detect all of these things at this point. But if we're going to make this change to a biological definition, well, then now we have very specific targets for Alzheimer's disease treatment, or at least therapeutic studies. So this figure here that you see, that blue-looking thing, that's a neuron, that's a brain cell. And there's a bunch of arms and legs coming out of it. Those are axons and dendrites. They're just terms for how we're communicating with other brain cells. But you see a beehive-looking structure in that figure, and that's the synapse. That's the important spot where we're actually communicating with other brain cells. So if we're using this new biological definition, well then shouldn't we be able to reduce the amyloid buildup with our technology? Or if not, shouldn't we at least be able to prevent the formation of tau? And our pharmaceutical studies are actually quite successful in doing this in human beings. We can remove amyloid in people. But we failed in actually treating them. We are still seeing clinical symptoms, and we're still seeing decline over time, even though we've reduced the amyloid buildup. So if that's our definition and those are our targets, and we succeed in doing this, why are we not curing the disease? And I would make the argument that that's because our model is incomplete. And so I've drawn here something simpler, the boxes showing what we're currently working on. So this pre-beta amyloid, simply, we all have this original protein in our brain. But for some people, this protein becomes toxic and it's beta amyloid, and that induces tau, and that induces tangles, and eventually we have cell death. And again, if this model were 100% accurate, we would have cured Alzheimer's disease in human beings. But since we haven't, we're looking back at the questions that we've been asking during this whole process. And that's an important thing to do. Because one of the important questions is, why is it that some people develop the toxic protein and others don't? They develop these non-toxic amyloid proteins that actually may have some purpose and are eventually cleared in the brain. What is it about beta amyloid itself that makes it act like a prion disease, like chronic wasting disease, where it generates more of itself in this positive feedback loop? Why is that? Why is it that beta amyloid in general induces tau changes? What is it about beta amyloid that's causing that? And lastly, why is it that in some people you have tangles and you have plaques, and that leads to cell death and symptoms, but in other people you have tangles and plaques and their cells are living and they don't have any symptoms? And so I think when you take a step back and you look at all these different questions we're asking, it really begs the question or the belief that the Alzheimer's disease pathway is more complex than we've given it credit. But I would make the argument that these factors making this pathway more complex, may actually be quite useful to us, not only in understanding the disease and understanding aging, but in identifying new targets for modifying and ideally preventing the development of this disease. And I want you to take a look at that last part of this figure. Why is it that in some people who have tangles and plaques, their cells die and they have symptoms, whereas in other people, they have the same pathology but no symptoms? Because this has been documented over the past few decades. We have many autopsy slides or autopsy studies looking at people with lots of Alzheimer's disease pathology but no symptoms. And in fact, people from Milwaukee contributed to the NUN study, which is very well known. And this was one of the important pivotal studies showing that people can actually have this disease and not be expressing the symptoms. Because in essence, it's the symptoms that bother us. It's not necessarily the disease in the brain, because we don't know about that. We're not feeling that pathology. And so a reasonable hypothesis is that there's such a thing as cognitive buffer. And so in this figure here, this is similar to the one I've shown you in the past. But at this point, I've also drawn in a dotted line called an abnormality threshold. So once you cross that line and you're beneath that, you're having clinical symptoms, the things that really bother us. And then there's this red curve. So this group of people has a low cognitive buffer or low resilience. And what that means is their brain cannot withstand a lot of insults. The tau, the amyloid, it's causing damage, and they're declining faster. The rate of decline is faster, and therefore they're being diagnosed sooner. They're crossing that threshold sooner. But if you're someone in the blue line, your graph is shifted upward and to the right, and that would imply that your brain can handle more insults. It takes more insults for you to actually have decline, and therefore your decline is slower, and you're being diagnosed much later. And so it's because of this concept that our research center, among many others in this country, are addressing modifiable risk factors that will impact disease course. And so we're in particular looking at physical activity, diet, stress reduction, sleep, cognitive activity, social activity. And then also other centers are looking at the other important senses of hearing and vision and smoking cessation. So I'm going to cover the top 5 with my remaining time. But this is not a novel concept. In 2015, the FINGER study came out. So the Finnish geriatric study to prevent cognitive impairment. It was a 2-year study. It looked at over 1,200 people in the prime of their life, 60 to 77. And it was a multi-domain intervention looking at diet, exercise, cognitive training, and vascular risk counseling and education. And what they showed is that over 2 years, they actually had improved cognitive performance. Arguing that my curve is wrong, that we're not showing a decline, you can actually show an improvement, an upward slope. And so our own center is building off of this, and we do a lot of work on exercise. And so Dr. Ozioma Okonkwo, one of our main researchers, has shown that moderate physical activity is associated with less amyloid buildup in the brain. Now, he's not saying that physical activity caused less amyloid buildup, but that there is a strong relationship there. So in this figure, age again is on that horizontal axis, but on the vertical axis is amyloid buildup. So as you go from bottom up, you have more amyloid. And what he showed was there's this red line. Those are people who are physically inactive. And over time, their brains are accumulating more amyloid, which many other studies have shown. But then what was very interesting is that in people who were physically active, over time, their brain amyloid levels stayed the same. He defined people who were physically active as those who did 30 minutes of moderate exercise 5 days a week. Now, he went on to show that cardiorespiratory fitness, just your overall fitness, was also associated with our brain functioning. And in fact, it strengthens our brain. So in these 3 figures, I want you to know that the horizontal axis is fitness. So as you go from left to right, you're more physically fit. Your cardiovascular system is strong. And then in the upper left-hand figure, that's a hippocampal volume. So as you're going from bottom up, you have a more volume, bigger brain. So in those people who are more physically fit, they had larger brains. That's also been shown in other studies. But in the upper right-hand corner, now we're looking at glucose metabolism through one of these fancy glucose PET scans that we can do both in clinic and in research. And again, that glucose PET scan, it shows the health and vitality of our brain cells. the healthier they are, the more they're churning through the glucose that we give them, and it lights up on the screen. So what we're showing here in this figure is the more fit you are, the more active your brain cells, the healthier your brain cells are. And that bottom left one, that's looking at amyloid buildup. So again, from bottom up, you have more amyloid. So as you are more physically fit, going left to right, you actually have less amyloid. Again, not saying one's causing the other, but that there's this very strong relationship. And then he did something very interesting. And he looked at people who just had high amyloid. And he asked the question of, well, among these people who all have a lot of amyloid, does being physically fit make any difference on your cognitive performance? And this figure is really complicated. It's quite small, so I don't expect you to be able to see it. But it's a trigger for me. It's a cue for me to tell you the answer is yes. Among people who are physically fit, that had high amyloid, they performed better on certain testing than those who were not physically fit, suggesting that physical fitness may negate some of the negative effects of beta amyloid in the brain. Which leads one to ask the next question, well, what other factors affect cognitive decline? Or what other factors interact with amyloid that affect cognitive decline? And my colleague, Dr. Lindsay Clark, asked this question and looked at people with amyloid plus or minus hypertension or obesity. And so in this figure, you have this very pretty figure. You have age on the x-axis. And then on the vertical axis are two specific types of cognitive performance, verbal learning and memory. And I want you to, in the middle, it's hard to see from where you guys are probably sitting, there's a control group. It's this black line, and that represents the anticipated decline with time. But what she found was that in people who had amyloid and high blood pressure, or amyloid and obesity, their rate of decline was greater. Or another way of putting it, those who had amyloid but did not have any of these other cardiovascular risk factors, their decline was not as great, suggesting that these other factors, our other conditions, are interacting with amyloid, causing changes in our brain or affecting our cognition. And when I think about obesity, I often then think about food. What is it that we're actually eating? And the MIND diet is very popular. It's been very well publicized. It is the Mediterranean diet and the low-salt diet combined, along with some other antioxidant foods. And Dr. Martha Claire Morris, who's at Rush University in Chicago, she's very close to our center, she looked at people who followed this diet over years, and she broke them into groups, those who followed it the least, the middle, and the most. And what she found was that those who followed it in the middle had a 35% risk reduction in developing Alzheimer's disease. Those who followed it the most had a 53% risk reduction. Now that's similar to the Mediterranean diet, which is 54%, or purely the low-salt diet, which is 49%. But the MIND diet's a little bit more lenient. It's a little bit easier to follow. It allows for some of those luxury items like fried cheese curds or dessert, a little bit of wine. It's something that more people can get on board with. And she also compared the people who followed it the most to people who followed it the least and found that those people's brains were actually 7 years younger than the people who followed it the least. Now that's a statistical way of simply expressing the health of your cells does depend on the food that you eat. And the people who followed this diet tended to have healthier brain cells. So then when I think about food, I often then move to the gut. What is it about our gut microbiome that could be contributing? And at UW, there's a lot of rat research that suggests that certain gut microbes increase your propensity to become obese, given the same diet to other rats that don't have those microbes. So with that in mind, Dr. Barb Benlin did the MARS study, Microbiome and Alzheimer's Risk Study. And she looked at the stool, yes, the stool of all, well, not all, many of our participants at the ADRC and RAP. And she compared those with Alzheimer's disease to those with control and looked at the diversity and the abundance of the microbes. In essence, asking how many different kinds of microbes are present and how many of each of them. She also looked at the relationship between certain gut microbes and these biomarkers of Alzheimer's disease. And what she found was very interesting. In people with Alzheimer's disease, there was less diversity in their gut. And this has been shown in other neurological disorders, Parkinson's included. She also showed that the relative amounts of certain bacteria were different in Alzheimer's disease. And lastly, in people without dementia, there was still a correlation, an association between certain amounts or certain types of gut bacteria, and brain amyloid in spinal fluid. So she found that people who had more Bacteroides, a certain type of microbe in their gut, had more amyloid in the brain. Now these findings were so important that we've now launched a new study called Ambition, which is a feasibility study where we're actually going to perform oral fecal transplants in people with Alzheimer's disease. This traditionally has been reserved for people with stool infections, but we're going to do it under supervision, but we're going to be looking at how feasible, how safe is this, and can it change the gut microbiome? More to come on this. This study is only just starting to be enrolled. Now, stress is another really important factor. We know that stress can affect our brain and its function. And when we experience chronically high levels of stress, we release this hormone called cortisol. Has its own effect on our cognition and just the structure of our brain. So this study was just from 2018, and it showed that high cortisol levels were associated with worse memory and visual perception, but they are also associated with lower total brain volumes. In essence, the opposite of exercise, where you had bigger brains, now we have smaller brains. This was more evident in women, and women are more affected by Alzheimer's disease, and it had nothing to do with the known genetic risk factor of ApoE4. Now, our own center at RAP has looked at just the number of lifetime stressful events in your cognitive performance. And in this graph, you have just the number of events on the horizontal axis, and on the vertical, you have two particular types of testing, speed and flexibility. And when you can see this downward slope, as you have more events, your performance and processing speed declines. And that's really important from a population standpoint, because we know that stress and stress burden is not distributed equally in our population. But even the perception of stress can affect our brain, whether it's real or not. And so in this study from 2014, they found that increasing levels of perceived stress was associated with worse cognitive testing, faster rates of decline on that testing, and a 30% increased risk of developing mild cognitive impairment, regardless if you were black or white. This was also supported by a study that was just recently done in 2016, which has showed very similar findings. And in clinic, when I'm talking to my patients about stress, the next logical part of the conversation is, how are we sleeping? And we know from Dr. Barb Bendland's work that sleep and poor sleep is associated with those biomarkers of Alzheimer's disease in healthy adults. And so Dr. Bendland looked at RAP participants' responses to the sleep questionnaire. For those of you that are RAP participants, we do use the hours of data that you provide us with those questionnaires. And what we found was that participants that reported less adequate sleep, greater somnolence, and more reported sleep problems had more amyloid pathology in their spinal fluid. And I'm not going to explain this very complicated figure on this slide, but it was done looking at both spinal fluid, but also confirmed a year later on amyloid PET scans. The last thing I want to talk about is cognitive enrichment. So we know through our own Dr. Kim Miller at the RAP study, the more cognitive activity you have, the less decline we see in your cognition. So in this figure, again, age is on that horizontal axis. And on the vertical axis is this group score of cognitive performance. The green line that you see, that is, again, the expected decline that we anticipate with age. And the blue line that points upward is the course of someone who is very cognitively active. Now, I don't know if after more better. And then the red line shows people who are less cognitively active, and there's a steeper decline. We also know from prior studies that lifetime cognitive engagement is associated with that beta amyloid level. And in 2012, the study was done, and it showed greater participation in cognitively stimulating activities was associated with reduced amyloid buildup. They also found in this study that it was particularly strong when you're cognitively engaged in the early and middle part of your life. So I want to leave you with this question. Can a concerted change in multiple lifestyle factors affect Alzheimer's disease? Can we move from this figure on the left to this figure on the right? where we have less pathology building up in our brains, therefore a higher tipping point, a slower decline from that normal aging trajectory, and possibly a delay in the diagnosis of MCI and possibly prevention of the diagnosis of dementia. And that is what our research is looking at. Now, for those who are interested in knowing other things that we're doing at our research center, other studies, I have a podcast called Dementia Matters, where we meet and discuss with our researchers, what are they doing exactly, what are they finding, and what are we hoping to find in the future. It's free, it's on our website, or you can Google it, or you can find it on iTunes. But with that, I'd really like to thank you again for listening, and I think I have some time for questions.
Thank you, Nathaniel. We have a time for one or two quick questions.
Thank you for being here today. What types of foods can we eat to get the right stuff in our gut?
Yeah, so one of the things that we found is that the diversity of food leads to diversity in the gut. And so the number that's actually been shown is 33 different types of vegetables or 33 different types of plant-based foods every week. And it's actually much easier than you think, because even bread, that counts as a grain. And so we do find that fresh vegetables, lean meats, fat even, and then salmon in particular seems to be a healthy diet. Variety. Variety is key, trying to avoid processed foods, trying to avoid packaged foods.
Hello, thank you for all that great information. I was thinking when you were describing your top four, how they actually are connected. Please talk about this a little bit, how they're connected, because if you do eat better, you will sleep better. If you exercise more, you do tend to want better food, and you do sleep better. So how those four work together, and there isn't like one panacea, like, okay, if I eat kale, I'm not going to get Alzheimer's or something. Okay.
Yeah.
Thank you.
Well, no, actually, you answered your own question. They are all working together. People who are physically active tend to sleep better. People who sleep better tend to have less stress, that we tend to eat better. We know that physical activity actually can be involved in our gut microbiome, and that stress and being cognitively enriched reduces our stress level. So they are all interacting with each other, and there is no silver bullet to this. So the mind diet happens to be the most well-studied, but it isn't that you eat kale or you eat a lot of blueberries and things are going to be just fine. You know, it really will be a whole program. It can't just be one of these things. It really is changing your life in a way that you want to be healthy, you want to age well, and that we're really focusing on wellness.
Thank you very much.
Yeah.
Thank you very much, Nathaniel. We are adjourned.